And last but certainly not least, we have Dr. Joseph Anthony Tumbocon. Dr. Tumbocon is faculty and head of glaucoma at the Department of Ophthalmology at St. Luke's College of Medicine. He's known to be a skilled and exceptional glaucoma and tube surgeon and has been invited to speak at many international conferences on tube surgery. Dr. Tumbocon will argue that the well-established Ahmed and Baerveldt tubes would be a better choice in the context of medically uncontrolled glaucoma with failed trabeculectomy. Thank you,
Thank you,
Joseph.
Shelvin. Yeah, thank you, Shelvin. First of all, I would like to thank the Asia Pacific Glaucoma Society, the All India Ophthalmologic Society, and of course, Dr. Tanuj Dada for inviting me to give a talk. My topic for this session, my assigned topic for this session is Ahmed and Baerveldt tubes in medically uncontrolled glaucoma with failed trabeculectomy. These are my financial disclosures, none of which are relevant to this talk. Now, when I'm presented with this type of scenario, there's a couple of questions that I would like to ask. First, can the bleb still be resuscitated either by needling or revision? If not, is there significant conjunctival scarring that increases the risk of failure with just a plain repeat trabeculectomy? Is there a cause of initial failure still present, such as recurrent or chronic uveitis? Are there a presence of other risk factors for failure with a repeat trab, like a young age or even angle neovascularization? If the answers to any of these questions is yes, then I would prefer to put an aqueous tube shunt, such as the Baerveldt implant. Now, other considerations is the ability to the patient to follow up, such especially in this COVID pandemic. Of course, in countries wherein the implant is an out-of-pocket expense, we have to take into account the financial considerations. These are the implants, aqueous tube shunts that I use. The Baerveldt 350 and the Ahmed implant has been around since the 1990s. The Multino 3 is a totally different implant from the first generation. The AADI is similar to that of the Baerveldt, and the newest kid of the block, as Dr. Kong mentioned, is the Paul glaucoma implant. Now, I prefer to use the non-valve Baerveldt 350 implant if my priority is to achieve the lowest IOP possible. On the other hand, I prefer to use the Ahmed glaucoma valve implant if I need immediate and controlled IOP reduction, especially in eyes that have a higher risk for hypotony-related complications. Of course, in patients that have maybe a moderate or early disease with just uncontrolled IOP. Now, there are advantages of these two types of implants. First, it has a long track record and has withstood the test of time. The Baerveldt 350 has been around since the 1990s and has largely remained unchanged. The Ahmed implant was introduced in 1994. There has been some change in the design of the plate and the material, but the valve mechanism is practically the same as when it was introduced. Now, this is an important aspect since other implants have been developed but did not survive the scrutiny of time. Now, we look at the physical characteristics of the implant, the specifications. I agree that the tube internal diameter, the internal diameter of the tube of the Paul implant is much smaller as compared to the other available implants. And this is an advantage in terms of decreasing the risk of hypotony. But does it really matter? Because even if you put an intraluminal stent, depending on the size of the tube, if you put a 4O Prolene, you could decrease the size of the functional internal diameter to approximate that of the Paul implant. And if you put a bigger intraluminal stent, you could make it even much smaller. Another important reason why I prefer Baerveldt and Ahmed implants is there's relatively strong evidence available supporting the use of these devices. I will concentrate on the TVT, AVB, and ABC studies. These are all the 5-year outcomes of these randomized clinical trials. Now, for the TVT, or the tube versus trabeculectomy study, this included patients who had previous trabeculectomies and or cataract surgery with medically uncontrolled IOP. They were randomized to either a Baerveldt 350 implant or underwent trabeculectomy with mitomycin C. And what they observed was the IOP reduction and the number of glaucoma medications were similar in both groups. However, the probability of failure for the trabeculectomy group was higher, and so was the number of reoperations. And with this study, it seems that for this group of patients, a Baerveldt implant or a similar implant would be the better choice rather than a repeat trabeculectomy. Now, for the ABC and the AVB studies, the ABC studies, the Ahmed Baerveldt comparison study, and the AVB is the Ahmed versus Baerveldt study. They have similar study designs, similar population, intervention, comparator, and outcome measures, with just the AVB study having a little bit more stricter primary outcome measure. In the interest of time, I will just discuss the pooled analysis of these two randomized clinical trials and discuss their 5-year outcomes. In a nutshell, both implants was effective in lowering the intraocular pressure and decreasing the number of glaucoma medication while achieving similar visual outcomes. The Baerveldt had lower IOPs at 5 years while also needing less medications. There was a higher probability of failure with the Ahmed, and also the Ahmed required more additional glaucoma surgery. However, the incidence of hypotony was quite low for the Ahmed group, wherein only one patient out of 267 experienced this complication. Now, going back to the question, which is better for this clinical scenario? Is it the Baerveldt, Ahmed versus the Paul glaucoma implant? Well, as mentioned earlier, there's really no strong evidence that directly compares these implants. Well, maybe we could use the 1-year outcomes of the Paul glaucoma implant study that was published in 2020 and compare it to the 1-year outcomes of the ABC and AVB studies. However, we cannot directly compare these the RCTs with the Paul glaucoma implant study, because if you look at the mean treated baseline IOP, the IOPs in the ABC and the AVB studies was much higher as compared to the medicated IOP of the Paul glaucoma implant study, suggesting that the patients included in the 2 RCTs had a more refractory glaucoma as compared to the ones in the Paul glaucoma implant study. So we need more RCTs directly comparing the implants. And of course, with a longer observation period, we need at least 3 or 5-year follow-up to make sure to know which one is actually better. So what are again, to sum up, the advantages of the Baerveldt, the Ahmed implant? It has a long track record. It has passed the test of time and is widely available worldwide. The Baerveldt is quite versatile. There's a lot of experience. A lot of surgeons already know how to use the device. The Ahmed implant, on the other hand, has a low risk of hypotony, and this has been repeated in different RCTs and other trials. There's reasonably strong evidence available to support their use in this clinical scenario. But ultimately, it is in selecting a device, the following should be considered. Again, the urgency of lowering the IOP, the target IOP that you are aiming for, the familiarity of the surgeon with the device, and of course, the personal outcomes. And of course, taking into consideration the evidence available to support the device that you select. Thank you very much for your attention. And I'm just going to plug, again, the Asia Pacific Glaucoma Congress. Those who want to submit the abstracts, it's still open up to the end of the month. Thank you very much for your attention.
Well, thank you very much, Joseph.